Yes, good. All right, it's 3 o'clock. I think we might be 15 people. Okay, I think everybody is here. Good deal. So you might have also gotten an email if you didn't get your OB math assignment completed. I've given you some feedback on your OB calculations. So if you still don't know how to do it after you look at what you might have missed, you need to let me know. Okay. I did put up a math video. Did everybody see it? I put it up as a link and it didn't work. And so then I put the video up itself. Okay, good. All right, so what we'll do now is so you're on Zoom on your computer. So open up a new window or a new tab and go on to Canvas to where your quiz is.
Is it okay to keep Zoom on my phone and use my
computer? Yeah. Oh, yeah, yeah. You can even be on Zoom on your computer.
We can be on both at the same time.
Mm-hmm. Okay. For the quizzes you can, not for the exams, but for the quizzes you can.
I was just wondering if we're able to switch back over to the laptop after the quiz.
If you're already signed into Zoom on your phone, you can. Yeah, absolutely. Okay. So during the quiz, you must be very quiet. Keep yourself muted. I can tell when you're finished the quiz. So don't sign out of Zoom. Stay right where you are. You may turn your camera off when you're finished taking the quiz. Okay. But don't sign off of Zoom. Just stay on Zoom until everybody's finished. When everybody's finished, then I'll start up again. Okay. All right. So is everybody on the quiz? Do you see it?
I have a quick question, please.
Yes, Cassandra?
Are we going to need like a script paper or a calculator for the quiz?
You might need a piece of scrap paper for the math exam or the math question. Okay. Oh. Yeah, so if you want to grab a piece of paper, you may.
Okay, thank you.
Your notes need to be, and your books all need to be put away. Okay. If you look up an answer and you're not allowed to, okay, don't use your phone to get onto Siri and ask a question. Don't look up any answers, okay? I need to trust that you will not look up an answer or use a note, okay? If you do, you're going to run out of time because you only have a minute and a half for each question, or a minute and a half for each question. Okay. Okay, so well, when you get there, I'll give you the code that you need to get in. And your time starts when you begin the first question. Is everybody there on their Canvas?
Yes.
Yes? Nod your head, please, if you are. All right, awesome. So in the chat on Zoom, I have the code. Uppercase letters. O-N-U-R is the code to start the quiz. O-N-U-R, all in uppercases.
Are we good to go?
You may go ahead and start. Okay, everybody is finished? All right. I can't go over the quiz with you right now because I have more students to take it this week. So I wanted to briefly pull up this one PowerPoint that I sent to you, and I usually don't go over it. So that you can, I started at the very bottom here, but this PowerPoint seems boring. It's chapter 8, but it does go through a lot of just general information. And some of this information we're going to go over today, and some we're not. Okay, so if you have any questions about this, then I would read through it if I were you. Print it out if you want to, and make notes in it as you read your book or however you want to do that. Okay. So that's that PowerPoint. So I'm going to start today with a case study just to go over some terms for this second week. Okay. Do you remember that we talked about high risk situations? In other words, women in their reproductive years, and the fact that half of pregnancies aren't planned, and some of the situations that a client might be in when she finds herself pregnant. She might not be at a best health at that point in time, and other things. So I want to talk to you about a client. She is a pregnant adolescent. And so let's go through this a little bit. Can everybody see my screen? The pregnant adolescent. So what things come to mind just right off the top of your head about a pregnant adolescent?
Not fully developed.
Okay. So we're concerned about what sorts of things?
Hormones and just the anatomy of the adolescent not being prepared to carry and give birth.
Okay. What else might you think about? Nutrition? What else? When you think of an adolescent, if you see an adolescent walking down the street and she's pregnant, what things come to mind?
Too young in general.
In general? What'd you say? Did I?
Possible lack of education on prenatal care.
Okay, she doesn't know how important it is, maybe? If she's resources, absolutely. Does she know what she needs to do? If she's short, if she doesn't have any insurance, what can we help her do? Okay,
Income.
her income. Yeah,
Provide her
And
resources.
I'm sorry, what'd you say?
Provide her contacts for the resources so she can get that provided.
Okay, okay, so transportation issues. Okay, so her name is Abby, and so she's come in for her very first visit. She is still in her first trimester, okay? And she comes in and she tells you, you're the registered nurse in the clinic. She tells you that she's having some presumptive symptoms. Well, she wouldn't say that, but what presumptive symptoms could she be experiencing that make her think that she is pregnant?
Nausea, vomiting,
Okay,
missed period,
what do we call a missed period?
amenorrhea,
Yeah,
Yes, that's it.
amenorrhea.
amenorrhea.
Yeah, amenorrhea. Good, good. So those are some things. So nausea and vomiting, amenorrhea. What else?
Tender breast.
Okay, tender breast. Good. Okay, she might be urinating a lot, right? Fatigue, that sort of thing. So the next thing we usually do after we check in our client, do vital signs, and she tells us why she's come to the office, is we do a physical exam. But we also do a urine test. We check her blood pressure and all that. We do a urine test to see if she is pregnant. And a urine HCG test is not a positive proof that she's pregnant. Okay, so it's a probable sign, okay, but it's not a positive sign of pregnancy. Because if she's on certain medications, it could be a false positive. Okay, it shows up positive, but it's not really accurate. Okay, so certain medications can cause that. Okay, so some other probable signs are things that you see as a registered nurse when you do your physical examination. So probable signs have to be measurable. You have to either be able to palpate or do an examination to make you think that she probably is pregnant. Okay, so not only an HCG test that's positive, but Goodell's, Hagar's, Chadwick's, the uterus seems to be enlarged. She might be having, if this was like the second trimester, she might be actually having some fake contractions. And that's what we call Braxton Hicks. She's feeling some pressure on the sides and in the front of her abdomen. You might notice increased pigmentation. Okay, she might have some things going on with her skin. And then blottement. Okay, so we have to identify what these things mean. Okay, Goodell means that her cervix is soft. Hagar signs, and I have pictures I think I gave to you about the Hagar sign, is when that isthmus of the uterus, you have your uterine body, you have the cervix down below, and then in between the cervix and the uterus itself, the lower uterine segment gets soft, and it allows that uterus to flop over. Okay, and that's why it's on top of the bladder now, early in pregnancy. And this makes her want to urinate a lot. So that's Hagar's sign. The flopping over is the actual McDonald sign. Chadwick sign. Who knows what I mean by Chadwick sign? Anybody know? Okay, the Chadwick sign is when we do our examination and we're maybe doing a speculum exam and we see that the cervix and the inner vaginal walls have a blue tint to them. Okay, it's called Chadwick sign. It's just a lot of blood in the area. We're going to be talking about what estrogen does. Expanding blood vessels have more blood in the periphery, so it tends to be bluish. If she has varicose veins, they're going to worsen in pregnancy. If she has hemorrhoids, they're going to worsen in pregnancy. Okay. So, and then Braxton Hicks, we talked about pigmentation, some of the skin changes. Can anybody think of a skin change in pregnancy? And it's
On the
caused by,
breast.
I'm sorry?
There's a pigmentation change on the breast. There's also the line on the
And what do we call that line on the stomach?
IA.
Linea nigra. Yeah. She also might have the melasma on her face, the pigmentation on her face. Okay. And then blottement. Blottement is when I do a bimanual exam, I've got my left hand on top of her lower the suprapubic area, because I'm trying to palpate. And then I've got two fingers in the vagina, and I'm going to push up on that cervix. And sometimes I can actually feel the vibration of the fetus. Now, she has to be far enough along. You know, she has got to be 10 weeks anyway before I would feel that. So those are all probably she's pregnant. But still, we're not sure. Okay. Positive signs. So when can we tell our client she's pregnant? When we actually see a fetus or an embryo on an ultrasound. Okay. Or what's the other one?
Blood work?
Nope, that's not a for sure one. And it's not even in here. It's a Doppler. A Doppler. If I take a Doppler and put it on her lower abdomen, I might be able to hear the fetal heartbeat. And we can hear that as early as 9 weeks. At 9 weeks, I have found fetal heart tones. Now, if you have an obese woman, you might not hear until week 12. Okay, but usually by week 12, if we don't hear it, what's another option? What do we need to do? If we can't hear a fetal heart tone, if she comes in and she tells us her last menstrual period, and we determine how far along she is, and let's say she's 12 weeks, and we can't hear a fetal heart tone, what could be something we could do to verify that she is pregnant?
Sonogram.
Yeah, an ultrasound. Yeah, an ultrasound. Yes. So an ultrasound, fetal heart tones, an incidental x-ray. We really don't want to do x-ray during early pregnancy. It can cause damage to the fetus. Okay. And then if she's far enough along, if she's waited and she hasn't gotten any care, and I put my hand on her belly and I can feel the baby move, that's also a positive sign. Okay. So presumptive, if you try to remember these in the setting of admitting a new client into your practice, when she comes in and she tells you her symptoms, she thinks she's pregnant. What are some of her presumptive symptoms? What are we're presuming she's pregnant because of what she's telling us. Okay. The probable signs are what I see or what I hear. What I see, not what I hear, what I see or what I palpate. Okay. Those are probable signs. And then the positive, we have to hear the baby or see the baby. Does that make sense to everybody? You do need to know those. Okay. So we have our Abby here. And so we are going to do an interview. We're going to ask her about her history, not only her family history, her personal history, but especially her obstetric history. Has she ever been pregnant before? We're going to categorize this pregnancy. So we're going to talk about the GTPAL today. Is anybody familiar with the categories? Okay, gravidity.
Gestation and the P is the pregnancy. How many times they've been pregnant, how many live births.
And yeah. So we can put it in a category, right? And so we have to determine how far along she is. So we use Nagel's rule. Okay, we take the first day of the last menstrual period. So if I tell you that she had a period January 4th, we're going to go back 3 months, add 7 days, and then push it into the next year. Okay, so January 4th, go back 3 months. What's 3 months? What's 3 months prior to January?
October.
October, and then we're going to add 7 days. So that would be October 11th.
Okay.
And since it was last year, she'll be due October 11th in 2023. Okay, so we'll practice those. So that's how we estimate when she's due. And that's called Nagel's rule. Okay. Some other terms that you need to know, and let's determine. So, nulla gravida, multigravida, prima gravida. The word nulli means none. Yes,
Professor
Crystal.
Zeller.
Can you post this PowerPoint for us to have?
I hadn't done that, but the other PowerPoints should have the same information. Okay. But if you really want me to, I can. I will. Okay. So the prefix nulli, N-U-L-L-I, means none. So a nulli gravida is a client who's never been pregnant before. So our client, Abby, is a nulli gravida. Okay. She's a nulli gravida. She's also I'm sorry, she's not a nulli because she's pregnant now. Okay. She's a prima gravida because she's pregnant for the very first time. Okay. So you need to know these terms. So a pregnancy that ends before 20 weeks is only referred to as a gravida. Okay. Every time she conceives, it's called a gravida. Okay. If that conception or that pregnancy is delivered after 20 weeks, then we can call it a parity. If a pregnancy is delivered between 20 weeks and 36 weeks and 6 days, it's called a preterm delivery or a preterm pregnancy. And then between 37 weeks and 41 weeks and 6 days, that's our full term babies. And then a pregnancy that delivers 42 weeks or later is considered post-term. So the 20th week is what we call the age of viability. In other words, if a baby is delivered before 20 weeks, it's an abortion, whether it's medical, surgical, or spontaneous. We also call it a miscarriage. Okay, so anything delivered before that 20th week, we don't call them parities, we call them abortions. Okay, so all the other pregnancies after 20 weeks and beyond are considered parities after they're delivered. Now, I know this is a new concept and it seems very confusing, but we'll practice, okay? So if we have a client who's had 3 pregnancies and 3 full-term deliveries, what are we going to call her? A preemie, a multi, a parity, or a gravida? If she's had 3 pregnancies and 3 full-term deliveries, what would she be called?
Multi.
Multigravida, and also multipara. She's delivered 3 babies after 20 weeks, and she's been pregnant many times, 3 times. Okay. So when we talk to Abby, she shows that there is a risk for genetic disorders in her family and depression. Okay. If she has, and we need to know who it is that has that cystic fibrosis. Okay. That's a genetic disorder. Okay. It's a gene mutation. Okay. So we'll need to follow up with that. Okay. And so currently, her due date then is October 10th of 23. So she is 10 weeks and 5 days. Now, do you remember, should we be able to hear fetal heart tones? Yeah, because we can hear them as early as 9 weeks. Okay. So she is going to come back. She's in a hurry. She has to come back the next week. She's going to get some blood work done. Okay. So do you know what blood work we would need to do? Are you familiar with any of the blood work that we do for OB patients?
An HCG level?
Not always. We don't always check HCG levels. No.
Are you talking specific blood work besides just the standard like electrolytes and cholesterol and whatnot?
We don't check electrolytes and cholesterol in OB patients.
Oh.
This is another realm, okay? All right, that's fine. We can go over some of that stuff. All right, so extensive medical history. We want to know as much as possible about her. Thus, in her medical history, Any chronic illness? Does she have any chronic illnesses? Does she use alcohol, any kind of illicit drugs? What about her prescriptions? Does she smoke? Any exposures? Okay, prenatal vitamins, especially those, we need her to have folic acid. So is she taking prenatals? And then is she taking herbal supplements? All of these can affect her pregnancy. Okay, we also need to do some screening socially for depression, intimate partner violence. Has she traveled outside of the states? What is her immigration status? Because we have to determine, is she immune? Has she had her vaccinations? So, and do a cultural assessment. Okay, so Abby has a BMI of 19. Is that normal? What's a normal, an ideal BMI? Do you remember?
18.5 to 24.99.
Perfect. Yeah, 18.5 to 24.99 is ideal. Okay. She's an active young lady. Okay. She's a cheerleader. She's active in sports. And we still would want to do a 24-hour nutrition recall. Okay. We want to talk to her about what she eats and give her some guidance. Okay. And so family health history. So mother has a history of depression. Depression can be associated, can be passed on. It's I don't know of a specific gene, but it might be just lifestyle. But it is if I know her mother has gone through depression, I would certainly want to keep an eye on her. Her father is an alcoholic, okay, and she has a brother with cystic fibrosis. Okay, that's the link there. And then she has an older sister with substance use disorder. Okay. So that you can see why it's important to know what's going on in the family because it can affect her. So she's considered high risk. She's an adolescent. She has a brother with cystic fibrosis. So we need to know if she carries that same gene. Okay. Okay, gravidity and parity. Remember that parity is a pregnancy delivered after 20 weeks, no matter what happens, even if that baby wasn't alive, if it was a stillbirth, okay, is still considered a parity. So when you think of the letter G, the gravidity, you see the letters G, T, P, A, L there. This letter stands for how many times the client has conceived. That's the best way for me to explain it. Okay, no matter what happened to those conceptions or those pregnancies, it's just the number of times she's conceived. And then a full-term baby, how many of those conceptions reached 37 weeks and were delivered? Whether they were alive or not. Just how many of those pregnancies went beyond the 20 weeks and beyond into the 37th week? Those are full-term deliveries. Preterm deliveries are going to be those conceptions that survived up to 20 weeks and into 36 weeks and 36 days. They didn't get to 37 weeks, but it was beyond the 20 weeks. So that's the preterm. Okay. Abortions. How many pregnancies were lost prior to 20 weeks? Whether it was induced or whether it was spontaneous, or also known as a miscarriage. And then live births, how many pregnancies, how many children has she delivered that were live? Okay, so your stillbirths and your abortions are not going to be in that last column, only the live born babies. So let's try an example, okay? You have a pregnant multipara. So she's delivered more than two or more babies after the 20th week, okay? So she has a son who was born at 35 weeks, a set of identical daughters who were born at 36 weeks, and she delivered a stillborn 2 years ago at 38 weeks. and she had a spontaneous abortion 7 months ago. This is very complex, and the way I'm going to teach you how to do this is, number one, how many times has the client conceived? And that will give you your G. Okay, so what is her G? Anybody want to guess? What is her
Before,
group? Actually, it'd be 5 because she's pregnant now. Okay. Yeah, she's pregnant now. She delivered a son, a twin pregnancy she delivered, a stillborn, and an abortion. So 5. The twins are considered one pregnancy, okay? Just one pregnancy. We're counting the conceptions, okay? And then how many of those conceptions now were delivered after 37 weeks? How many in that, any 37-week deliveries?
Is it 2?
1.
Just one, the 38-week stillborn. The 38-week stillborn is a full-term delivery. Even though the baby wasn't alive, it's still considered full-term delivery, okay? The 35 and 36, so preterm, you've got 35-week pregnancy and a 36-week pregnancy. So those 2 preterms. And then her spontaneous abortion would be the abortion column. So how many babies were born alive? How many living deliveries?
Just 2.
You can use just 2. That's the 35 and the 36-week-old pregnancies. Okay. All right. So when we talk about blood tests, then we have such thing called OB panels. Okay. And we get blood type. I sent you a chart, but we need blood type. We need to know her RH status. We need to know, we do a CBC because we want to look at red blood cells. We want to look at platelets. We do testing for HIV, hepatitis, thyroid. It's a long list of blood work that we do. We also do some special testing because Abby has a brother with cystic fibrosis. We're going to do carrier screening. Okay. Carrier screening, we kind of do routinely for everybody. We screen for cystic fibrosis and sickle cell disease. For cystic fibrosis for everybody, and then everybody with dark skin will do the sickle cell test. We want to know if mother is carrying that gene. Okay, so genetic screening is carrier screening. Okay, is she carrying the gene? So autosomal recessive, cystic fibrosis and sickle cell are considered recessive genes. Okay, and then Marfan's and Huntington's is dominant. You don't need to know the dominant. Okay, so that's carrier screening, and we'll go into more details. We'll talk about this again. Okay, so maternal serum markers is another antepartum special test that we do in pregnancy. Okay, so we've determined that she's got the sickle cell, or I'm sorry, the cystic fibrosis history. Now we need to look at some other indicators or other markers that could be floating around in her blood. Okay, we call them maternal serum markers. Okay, markers that indicate maybe the baby is at risk for Down syndrome or alpha fetal protein high for neural tube defects. Okay, so the 2 that you need to know about are AFP is high and the HCG is low. Okay, so AFP and HCG are markers in her blood. They're protein. that's circulating in her blood. And if that level is too high, the AFP is too high and the HG is low, that means she's at risk for neural tube defects like spina bifida. Okay. If the AFP is low and the HCG is high, it usually indicates Down syndrome. Okay. So this is all you need to know about maternal serum marker screening. And we usually do the marker screen for everybody. Okay. Just to see if they're at risk of their baby having a neural tube defect or having some kind of trisomy. Okay. Do you remember what I told you about neural tube defects? What is the usual etiology we think that causes high AFP and low HCG? Does anybody remember?
Folic acid.
Folic acid. So if Abby has been taking prenatal vitamins and she was taking them right when she found out she was pregnant, and sometimes that's too late then, but she's been taking it, but her folic acid levels weren't high enough during those first 8 weeks of pregnancy. And the neural tube, which is the spinal cord, it didn't get completely covered with skin and tissue. So it was exposed and it caused damage. And it's called a neurotube defect. Okay. Her folic acid levels weren't high enough. Okay. So this test tells us that Abby's baby could have a neural tube defect. It's not a positive, it's just an indication. Okay. All right. So she comes in at her 13th week antepartum visit. And we need to discuss lab results, okay? So remember, young people are still growing, okay? And they might not be eating well, okay? So they're at risk for low birth weight babies, okay? So how would you address Abby and her weight loss?
Education on a proper diet and that she needs to eat more than she would normally.
Okay, so we need to talk to her. What is she eating and give her some guidance? Absolutely. Weight loss in the first trimester is not that critical. A lot of women might lose weight because of the nausea and the vomiting. We'd like to see weight gain between 1 and 4 pounds, but we don't always see that, okay? What about her urine was normal, but there was THC in her urine? Anybody know what THC is?
The marijuana.
Cannabis.
Yeah, cannabis. Yeah, cannabis in her urine. So how would you discuss that with Abby? What would you say?
Let her know that you're not judging her, but it's not good for the baby, especially this early in development.
Okay. So we need to ask her if she's been using it. Okay, we need to have that discussion. I think she might have it secondhand. It could possibly be secondhand. So whatever the situation, we do need to tell her the risk associated, okay? All right, she also had chlamydia in her vaginal culture. So we need to talk to her about, we need to treat it and we need to treat her partner. We need to find out if she has more than one partner. Okay, so we don't want her to have chlamydia. Chlamydia is a very fast growing infection. It can actually travel up into the uterus. She's mildly anemic, which is not unusual. Okay, her carrier screening for cystic fibrosis was negative. So her baby is not at risk for cystic fibrosis. Okay. But when we did the maternal serum markers test for AFP, the AFP was elevated. Okay. So we need to follow up with that. Does anybody have any idea what we do with an elevated AFP? Well, what we usually do is in an ultrasound, we're looking for signs of neural tube defect. Is it obvious on the ultrasound? And usually it's not until late in pregnancy. And even then, we can't always tell for sure. So it's not really diagnostic if there's a neural tube defect until delivery. Okay.
Is AFP the chart screen before?
Yeah, see, AFP high,
It's a
is
maternal
indicative.
serum marker.
yeah, is it? The AFP and the HCG are maternal serum markers. There's 4 markers that we test for, but these are the only 2 that you need to be familiar with. Okay.
Can you still encourage the patient to take like a folic acid? Can
Yeah.
you
Oh, yeah.
do that?
Yeah. We still want her to take the folic acid. Folic acid is vitamin B9, and you need it for growth.
So
Okay,
will
you
it
need it.
help to decrease the like how serious the whole NTD could be after birth?
If it's beyond 8 weeks, no, it's not going to improve anything. If it's beyond 8 weeks, some women don't even know they're pregnant when they're 6 weeks. And that's why, my recommendation that all reproductive age women be taking the folic acid. So that if they do happen to get pregnant, at least they have that in their system.
Professor Zeller, I had a question about earlier when you were talking about the Doppler and how early you could hear the heartbeat was like, what, 9 weeks or 10 weeks?
Yes, 9
So
weeks.
is that a stump on the abdomen and not transvaginal?
Oh yeah, the Doppler is just like you would use a Doppler to try to find a pulse in your foot, or if you have someone with peripheral arterial disease and you want to check their pulses and you can't palpate it, you would get a Doppler. Yeah, so we would just put the Doppler on her lower abdomen to find the fetal heart rate.
And so if they did a transvaginal ultrasound, then how early can they detect that heartbeat transvag?
Well, the heart starts beating at 3 weeks, but even if we did a transvaginal ultrasound at 3 weeks, which we won't, we're not going to see the heartbeat yet. We can't see the heartbeat until about 6 weeks.
Okay, I was just curious because I had it at 7 weeks and 4 days, and that's why I was wondering how early is the earliest you could hear it.
Yeah, usually about 6 weeks. You can hear it, but you can also see it on the ultrasound. Okay, that answer your question. So a transvaginal ultrasound means we're putting our probe into the vagina because we're closer to the uterus, and right, if we're going through the vagina early in pregnancy. Because before 12 weeks, remember that uterus is still hidden behind the pubic bone. So if she's 14 weeks pregnant, we can just do a transabdominal ultrasound. So at transabdominal, you kind of want her bladder to be full, so it pushes up even more. But if we're doing a transvaginal, we want her bladder empty because the bladder would get in the way of the uterus.
Thank you.
All right. Any other questions about this? Okay. Do we want to take a quick break now? Okay, Jen says yes. So I have 58. Let's meet again at 10 after the hour. Okay, we'll take a quick break and then we'll jump into some stuff. So let's briefly talk about conception, fertilization, and development of the embryo. So what you need to understand about this is that the ovary releases the egg that was mature, and if conception occurs, or fertilization actually, the sperm and the egg unite and they become what's called a zygote. It grows, it multiplies, and it divides. Okay. It's during this tube life that an ectopic pregnancy can develop. Okay. So ectopic means being somewhere else than the normal channels. So an ectopic pregnancy is a pregnancy outside of the uterus. It can be actually on the ovary or in the abdomen. Of course, those don't survive, and neither do the fallopian tube pregnancies. Okay, so that is one of your assignments this week, is doing a case study on an ectopic pregnancy. Okay, so usually it takes 7 to 12 days for this zygote, which becomes what we call a morula and then a blastocyst. It takes about 7 to 12 days for that blastocyst to make its way down into the uterine wall. Okay. And then at day 15, it's referred to as an embryo. All right. And remember, we talked about progesterone last week. So progesterone is produced by the ovaries. Okay. When a woman becomes pregnant, when the egg is released, it leaves behind what's called a corpus luteum. And the corpus luteum then provides the progesterone that is needed for the conceptus to grow, multiply, divide. Progesterone also prepares the wall of the uterus, called the decidua, for the developing embryo. It's a massive supply of blood for that particular baby. Okay, so that's progesterone. Progesterone helps that tube move, and it helps the uterus relax so that it can be attached to the wall. With an ectopic pregnancy, it's very painful because tubes are probably no more than maybe 4 millimeters in diameter. They're very tiny. So if you have something growing in that tube and it presses against it, that's going to be very painful. And eventually it will rupture the tube and cause a lot of bleeding. So it's an emergency. Ectopic pregnancy is an emergent situation and usually requires surgery. Okay. And so you're going to see a low hemoglobin because she's bleeding. She's going to have increased white blood cells. And to diagnose, we usually do an ultrasound. So if Abby shows up at the office and she's having a lot of right lower quadrant pain, the first thing that comes to my mind is an ectopic pregnancy. So we would definitely want to get an ultrasound to rule out, to make sure that that pregnancy is in the uterus. Any questions about ectopics? Okay. So I'm skipping a lot of science.
Do you know if there's ever been a case of an ectopic that did survive?
No. No, I don't know of any cases. So when we're talking about chromosomal abnormality, I guess I should go back a little bit. Chromosomes. We call a karyotype an exam or a test to determine how many chromosomes someone has. So your karyotype, if you're a female, this is a female karyotype. So you can see that there's 22 autosomes, 22 pairs, and then you have a pair of sex chromosomes. So this is a normal karyotype. You see the 2 sex chromosomes down here, the 2 X's. Okay. Just so you understand. And then here's the male. Oh, let me find the male. Here's the male. So once again, you have 22 pairs of autosomes, and then you have 1 set of sex chromosomes here, an X and a Y. Okay. In Down syndrome, remember the AFP is going to be low in Down syndrome. And if we have a client that has a miscarriage, and we can do actually a karyotype on the tissue from a miscarriage, and we can determine if that baby had Down syndrome by looking at the chromosomes. Okay, so Down syndrome means that there's 22 hairs, except number 21, there's 3 of them. Okay, there's 3 chromosomes on number 21. So Down syndrome is called a trisomy. It's called a trisomy. There's other trisomies. There's a 13 trisomy. There's an 18 trisomy, and they cause different things. But usually 13 and 18, they don't survive. They might be delivered, but they don't survive very long. And then the X chromosomes. Let me show you the X chromosomes again. Here's 2 X's. And remember, the male has the X and the Y. So Turner syndrome is a sex chromosome abnormality, and so is Klinefelter, a sex chromosome abnormality. Turner syndrome is female, okay? So it's a sex chromosome abnormality. So sexual reproduction, sexual development are abnormal in these 2 kinds of clients. So Turner syndrome is a monosomy. I think that's this one. Well, there it is. Turner syndrome is a monosomy. There's only 1 sex chromosome, so it's mono. And Klinefelter is a trisomy. So Turner syndrome, what we see is sexual immaturity. Well, for both of them, sexual immaturity. Turner's neck webbing, some infertility, short. And we usually have to support them with estrogen. And then Klinefelter is mainly the males. It is the male. And because they have the extra X, they tend to be more effeminate or tall, and they're infertile. Their testes are small and their penis is small. They have poor muscle tone and poor language development. Okay, so that's the 2 sex chromosome abnormalities. You don't have to know the Turner and the Klinefelter for OB exams. I don't think they're on the HESI, but I don't know. So let's talk about inheriting. You know, if your mother and your father, when they conceive, they share their chromosomes to make a full set of chromosomes, right? If in a autosomal recessive pattern, remember we did the carrier screening on Abby, and she was not a carrier, nor did she have the gene or the disease. Okay, so an autosomal recessive. Now we're talking about cystic fibrosis and sickle cell and phenylketonuria, galactosemia. Okay, these genes are inherited in a recessive fashion. So both parents have to be carriers. Okay, for them to have any child with any trait, any gene, or any disease. Okay, so if they have 4 children, 1 of them would be a carrier, or 2 of them would be carriers. 1 would not be a carrier, would be normal, and 1 would actually have the disease, cystic fibrosis. So this is what we call recessive. So there's a 1 in 4 chance that this couple will have a child with cystic fibrosis. So if the father is carrying a gene for cystic fibrosis, and the mother is also carrying a gene, then there's a 1 in 4 chance that they'll have a child with cystic fibrosis or sickle cell or phenylketonuria. Okay, so that's what we call autosomal recessive, and that's usually what we're talking about in OB. And just to show you the difference for autosomal dominant, in other words, how a person passes on a dominant gene. So if this woman in this picture, she has, or no, it's the father, the male, that has Marfan syndrome. Okay, he actually has Marfan syndrome. His wife does not, his partner does not. So when they conceive, there's a 50% chance that each child will have Marfan syndrome. So it's dominant. Okay, 50% will have it and 50% won't. Okay. I just realized there's a typo on this. This little girl with the black dress and black hair, it says affected daughter. That should be unaffected. So the two children in the middle are safe. Okay, so that's dominant. So 50% chance that each child will get it. Whereas recessive, it's only a 25%. But sickle cell and cystic fibrosis are recessive. We really don't talk about von Willebrand. We do talk about that a little bit. And there's other factors that come into play. 12, 16. Okay, I gave you a sheet on embryology, the things that you need to know. You know, in the announcements, you don't memorize anything. Okay, don't memorize anything. Just know that at the beginning of the 9th week, our embryo is actually a fetus. It is fully developed. All structures are in place. Now they're not mature, but they're there, okay, at week 9. So here's a picture. And I think it was Jennifer is what somebody was telling me that, was it you, Jennifer? Telling us that there's you had an ultrasound.
Yeah, I had, well, they called it a threatened miscarriage because it was the
Oh.
placenta had formed over the cervix, so it moved back, so it knew to have a way for the baby to come out, and that blood wasn't all absorbed
Yeah,
in
yeah,
a small
yeah.
pocket. But when they did to see if it was still viable, they did the transvaginal at 7 weeks, 4 days.
Yeah. So this is an ultrasound of a 7-week gestation. You can still see the yolk sac here. Okay. Fetal pool just means where the heart is. Okay. Because this is still an embryo. It's not a fetus yet. Okay. So yeah. So if a client comes in within that first trimester and she's bleeding, we need to see, is she having a miscarriage or a spontaneous abortion, or it could be something else. It could be actually the placenta is so close to the cervix that it's bleeding. But oftentimes those placentas are called placenta previa. Oftentimes once that baby grows and the uterus grows, that placenta ends up being at the top of the uterus and it's fine. Okay, so here's our 9-week fetus, usually about 1 inch long is all. Okay, but you can see arms and legs, the head, the ears, and the eyes. You can't see the eyes, and the mouth and the nose. And you see the umbilical cord here, the feet, the butt. Okay, so let's talk about the structures. The amniotic fluid. Why does a baby need to be in fluid?
Helps
Well,
baby
it's
to grow.
yeah, they need to be able to grow. Yeah, they need freedom to grow. Okay, so it's shock absorbing fluid. It maintains the temperature of the baby at mother's temperature. So if mother has a fever, the baby's going to have a fever too. Okay, some immunoglobulin protection. I don't know if your book actually says that or not, but that's something that I kind of know. And then it keeps the umbilical cord free floating, because our umbilical cord is carrying the blood vessels. to the baby and from the baby. Okay. So the umbilical cord, it's the lifeline, I call it. It covers the blood vessels from the uterus to the placenta, from the placenta to the baby is where the umbilical cord has blood flowing to and from. Okay. It's got two small arteries, and those arteries carry the deoxygenated blood. And then the one large vein carries oxygenated blood from mom. And surrounding those blood vessels is what we call Wharton's jelly. And it keeps the blood vessels moist and cushioned. So it protects them. So the only purpose of the umbilical cord is to protect the vessels. Okay, it doesn't do any other function. The placenta, however, is the workhorse of the pregnancy. It's where all the action takes place in the placenta. And we refer to it as the exchange organ. It's a temporary organ. It develops soon as mother conceives, and it grows. And by 12 weeks, it's mature and it's producing progesterone for the baby. And it's allowing the blood exchange to take place. Okay. It doesn't actually exchange. It butts up against the vessels. So placental health relies on good uterine blood flow. So mother's blood pressure has to be high enough so that the blood is going into the placenta. And we don't want it too high because it reduces the blood flow. Okay, so what you see in this picture, it's a network of maternal blood vessels. I don't know if you can see this or not. Maternal blood vessels and fetal blood vessels interfacing one another like this. Okay, like this. They're not connected. There's no, the mother's blood does not go into the fetal blood. They're just next to each other so that the nutrients in the oxygen can be moved from one vessel to the next. Okay. So you have oxygen going through the umbilical arteries, through the umbilical vein to the fetus. You have the umbilical arteries taking deoxygenated blood and waste products from the fetus back to the placenta. You know, and I tell my students this every quarter, if you understand the important fact that adequate blood flow to the placenta, that means mother has to have adequate blood and blood pressure for that placenta to function at the best it can function. Okay, it really relies on that blood flow. So if you have a chance to look at some pictures of that. So fetal heart circulation. Remember, the fetal lungs are not functional during intrauterine life. They're bypassed. They get a little bit of blood, but not much. Okay. So the way the blood flows through the fetal heart is totally different than it does through the adult. The way the baby breathes is by drinking in amniotic fluid. That's the way they're practicing. Okay. They're practicing. So it comes into the baby's circulation. The oxygenated blood will enter into the inferior vena cava, and some of it will go to the right ventricle. But the majority of the blood coming into the fetal heart comes into the right atrium and bypasses the right ventricle. If you remember what it is in the adult heart, it goes to the right ventricle, right? But for the fetal heart, it goes to the left atrium because it's already oxygenated from mother. So if you could see the red line, goes into the left atrium, down to the left ventricle, and up through the aorta, and then out through the body. It bypasses the lungs. It bypasses the lungs when it comes up through the pulmonary artery, because we don't need, there's no oxygen in the blood to exchange. Okay, so it bypasses the lung, and that's called so that you have the ductus venosus because it bypasses the liver. The foramen ovale is the opening between the right and the left atrium. And then the ductus arteriosus is that shunt that will not allow a lot of blood to go to the lungs. So you really just have to study this chart. You're not probably understanding a whole lot unless you're familiar with this. You're just going to have to look at it and study it. Remember, fetal lungs are not being used for exchange. Okay. All right. So remember, so you're assessing, you delivered a newborn or a baby was born and you're doing your assessment. The cord was clamped, mother's head, skin to skin time, and you're doing a full head to toe assessment. And then, to double check, and you notice, you look at the umbilical cord where it was cut and you want to see how many vessels are in there. We usually do that right after delivery. So how many vessels are supposed to be in the umbilical cord?
3.
Okay, 3 vessels. So there's 2 small arteries and 1 vein, right? Let me go back here, see if I can't find that picture. See right here, 1 large vein with oxygenated blood and 2 little umbilical arteries. So there's 3 vessels. Okay. So your client, Abby, is asking you, how does a baby breathe when it's surrounded by fluid? Oh, where that came from. How would you answer Abby's question? Where did baby get his oxygen?
From the amniotic fluid.
Not from the amniotic fluid.
From the
From the
mother.
umbilical cord.
Cord.
Yeah, from the blood. So, we breathe air and it's got oxygen in it, right? And our lungs do the exchange and reoxygenate our blood, right? That's the adult or the child. Okay. But a fetus doesn't have to do that because the blood coming to it is already oxygenated. There is no drive to breathe. Okay. The oxygen is already in the blood when it comes to him. Okay. True or false? About the placenta. It is a temporary organ. Is that true?
Yes.
Yeah, because at the end of the pregnancy, it's gone. Okay. Is it true that it begins to calcify late in the 3rd trimester?
Yes.
Yeah. Does it connect to the maternal blood vessels for oxygen and nutrients?
Yes.
It doesn't really connect. It butts up against it, but there's no exchange. There's no blood transfer from mother to fetus. Okay. So it doesn't really connect. Okay. It has a high pressure flow from maternal vessels. The blood pressure coming from mother, from the endometrial arteries into the intervillous space where the baby's capillaries are. Is that a high pressure system or low? What'd you say, Janae?
High.
Actually, it's a low pressure system in there. Okay. For more blood volume. For more blood volume. And you'll understand that probably a little bit better later. Okay. The placenta is dependent upon adequate blood flow and pressure from the uterus. Is that true or false?
The placenta does act as a filter.
Yeah, it acts as a filter and it allows a lot of blood to come in. And so it does depend on the uterine blood flow. Okay, we need plenty of blood. Okay, does a placenta filter out toxins and alcohol from the maternal blood?
No.
No.
No, because that's how they get the fetal alcohol syndrome.
Yeah, yeah. Okay. So there's a lot of stuff in there. So, you know, I want to encourage you to ask questions as we go, okay? All right. So let's do, make my screen bigger. Okay, so this is a reminder, and I wanted you to have it as a resource about math, conversions. Like, for example, 30 mLs is 1 ounce, 240 is a cup. Remember, if you have a math question on an exam and it asks you to round, if you don't round it up, you get it wrong. Okay, so if it tells you to round it to the 10th place, for example, 2.39, round that up to the 10th place, it would be 2.4, right? Okay, if you round it to the 100th place, 5.656, you would round it to 5.66 since it's a 5 or greater. Okay, so you need to know how to round. If it tells you just do a whole number, you don't want any decimal point. So please pay attention to your math questions. I've had too many students miss math on an exam because I didn't round it. Okay. And the word bolus, some of you on your OB calculations gave me a rate of 200, or gave me a volume. Okay. 288 mLs. And while that's not wrong, that's not what it was asking you. It was asking you for a bolus means to give it all at once, okay? Whatever it is. Because we need to get the level of that medication into the client. And then maintenance, we're continuing that same medication, but it's on an ongoing rate. So it's a lower dose. Just want you to understand that. Not uncommonly missed on the OB. So remember what nulli gravida and prima gravida, multigravida, parity, age of viability starts at week 20. Viable means the ability to live, okay? So you could live, go through this. We went through GTPAL. So human HCG, okay, that's what those little pregnancy tests are that you can buy over the counter too. They recognize, they test HCG. So HCG is the earliest biochemical marker of pregnancy, either in the blood, the serum, or in the urine. We can see it, it's detectable as early as 7 to 10 days after ovulation. Okay, and then Nagel's rule, estimating the due date. We're going to add 7, we're going to go back 3 months, add 7 days, and then a year. Anybody want to practice that? So if your client tells you that their first menstrual period, their last menstrual period, the first day of it was June 21st, the first step is to go back 3 months. So June would be May, April, March. So March, and then add 7 days, March 28th. And so it would be March 28th, 2022. Okay. So you can practice those. Presumptive symptoms, remember, if she feels the baby moving, she's pretty far along. So I think your text says 18 weeks to 20 weeks is pretty average. Now, if you've had 3 or 4 children, you might feel it sooner. Okay. The first sensation of movement is called quickening. Okay. So fatigue, nausea and vomiting, breast tenderness, amenorrhea are presumptive symptoms. Probable signs, the positive HCG test. So my visual learners, this is what helps you. That's why I put pictures for you, because if you are taking an exam and they ask you about probable signs, I want you to remember the pictures. You know, the blue colored Chadwick sign, bluish tinted cervix and vaginal tissues, blotment, positive HCG, the softening of the cervix called Goodell's sign, Heger's sign, the softening of the isthmus, the lower part of the uterus, and blotment. And then the positive signs, ultrasound, fetal heart tones. So let's talk about a little bit of changes in the systems. Okay, so the breast, they become larger and more tender, and skin change, as we talked about, areola, the area around the nipple becomes darker. The uterus actually grows. It not only stretches, but it grows. In other words, more uterine cells are added to it. Okay, and it changes once it's the baby begins to grow, and we get close to 12 weeks where it becomes a larger baby and uterus. It's more up into the abdominal cavity now. So it changes shape a little bit. It changes in contractility, so it's more relaxed. And so that blood flow between the uterus and the placenta is huge. Okay, during pregnancy, 1/6 of the total of maternal blood volume in the whole body is actually in the uterus. Okay, that just tells you how important blood flow is, because good oxygenated blood to that fetus is very important. Okay, normally during pregnancy, white blood cells go up a tad. There's going to be more white blood cells in the urine as well. Okay.
Do the white blood cells go up because of the increased blood volume?
No, I think it's just a normal increase of white blood cells. It could be, but usually it's the RBCs that usually the volume goes up. That's a good question. But it could be. So the breast, as they develop and grow, remember estrogen is what causes growth of the breast. But breasts are actually functional for nursing or lactation at 16 weeks. They're fuller, they're heavy, they know how to produce milk. But they're not going to produce milk yet because prolactin is what causes the milk to be produced. And the prolactin levels during pregnancy are low. Okay. Colostrum is the first substance that's produced from the breast late in pregnancy, after the baby's born. It's available for the newborn, but it's beginning to develop in the second trimester. So here we go, fundal height. We don't usually measure fundal height until about week 20. What we mean by this is we're taking a tape measure and placing it down here on top of the bone, the pubic bone, and we're stretching it till we find the top of the uterus, which is called the fundus. Okay, so we do fundal height measurements usually after 20 weeks. Okay, so at 20 weeks, that top of that uterus should be right there at that belly button. When you palpate the top of the fundus, you can feel it. It's firm. It's right at the belly button at 20 weeks. So estrogen and progesterone then. Remember, estrogen is your growth hormone. Okay, progesterone supports the pregnancy, but they have other things that they do. But those are the two primary function of these hormones that are continuing to increase, and the level goes up as a pregnancy progresses. Okay, so more blood vessels, especially in the uterus. Increased capacity of blood vessels. In other words, the arteries and the veins can actually hold more blood during pregnancy because we need that blood flow for the uterus. Okay, so they vasodilate. So that's why if you've got a lot of blood pooling in the periphery, you tend to be more lightheaded. Okay, a lot more congestion in certain areas. Okay. So it actually goes from a weight of 4 grams to 70 grams. I'm sorry, 4 to 70 to even 1,200 grams at full term, the weight of the uterus. So when a woman is not pregnant, there's only usually about 100 mLs of blood circulating within the uterus. But when she becomes pregnant, by the time she reaches term, she might have 5 liters of blood in that uterus. That's a lot. And so if the uterus ruptures at the end of the pregnancy or during labor or from trauma later on, that's why massive hemorrhaging takes place. So what happens to the cardiovascular system? We've got a lot more blood, right? But we have even more plasma. Okay, we've got a lot of plasma. So we have this volume of blood. Red blood cells and plasma are both increased, but more so plasma. So it looks like when you look at the blood under a microscope, it looks diluted. Doesn't look like that. There's very many red blood cells. And we call that dilutional anemia or physiologic anemia of pregnancy. Okay. So the heart actually, because there's greater blood volume, the heart's working really hard during pregnancy. It actually grows a little bit. It becomes a little hypertrophic. Okay. Blood pressure might be lower in that first trimester. It tends to increase as a pregnancy. Towards the end of the pregnancy, it's going to be back to normal. Okay. And I have a picture of supine hypotensive syndrome. Can anybody figure out what that means? What does supine mean?
Like face up.
Yeah, Thomas, being flat down, face up. Yeah. So lying down flat is supine. If you have a large pregnant woman, or sure, a woman that's largely pregnant, super gravid, okay, and she's got this big baby and all this amniotic fluid and this big uterus pushing down when she's laying down, what's it pressing against? See that big baby laying right on top of that inferior vena cava. And there's an aorta in there too. So it's called aortocaval syndrome or supine hypotension. So if mother is lying flat on her back, it's going to reduce blood flow not only to her brain and her uterus, but then reduces blood flow to the placenta, right? And reduced blood flow to the baby, and it causes the baby's heart to drop. Okay. So let's go back. So larger heart, a lot more blood flow, the cardiac output almost doubles. So it's pumping a lot more blood. Okay. Also during pregnancy, the ability to coagulate is increased. It's because the coagulation factors in our blood are increased. The fibrinogen level is increased. So just know that she's at risk for blood clots during pregnancy. Okay. So there's your hypotensive syndrome or supine hypotension. What about the respiratory system? She breathes more, but she doesn't breathe faster. So she's in mild hyperventilation. She needs more oxygen for her blood, for the fetus. Her metabolism goes up. She usually needs about 300, 400 more calories a day. The kidneys are working harder. The more blood you have, the harder the kidneys have to work. They have to filter all that blood. The kidneys dilated. Women are susceptible to urinary tract infections during pregnancy because the dilated ureters and the spaces, urine tends to sit in the ureters a longer period of time. So risk for infection, urinary tract infection. And then here's your skin we talked about. We talked about the linea nigra, that line that goes right down the middle of the belly. And then the striae gravidarum are the stretch marks. So the striae gravidarum are permanent. They're, it stretches the skin and those are scars. So that's kind of permanent. They do fade, like in this one, it looks like it's fading. And they shrink a little bit. But everything else, the melasma, the linea nigra, and everything else usually resolves at the end of pregnancy. So this is progesterone that's doing this, skin changes. And then one important thing to know is that the musculoskeletal system changes in pregnancy too because of progesterone. It relaxes the uterus, but it also relaxes ligaments. Okay, so within the pelvis, the ligaments that connect the back to the hips and the hips to the thighs or to the legs, the femur, and in the front, the pelvic structures, it's more fluid. They move a little bit so they can expand for pregnancy. Okay, so sometimes she'll have some back pain or hip pain during pregnancy. And that's from the relaxin and the progesterone. Progesterone, sometimes we actually supplement a client with some early in pregnancy. If she has lower progesterone levels, we want her to have adequate progesterone for the pregnancy and to support that pregnancy. I just want to mention that. I think I might have mentioned it last week. And then the immune system during pregnancy is very quiet. Another reason why she's susceptible to infections during pregnancy. It doesn't react as quickly. It's very quiet. So, food, folic acid. Remember, we talked about it's the growth vitamin. Folic acid is B vitamin, B9. And with inadequate amounts or a deficiency, it can cause neural tube defects. So we need her to be taking 400 micrograms a day. Pica. Oral hygiene is very important during pregnancy. We need to have a healthy gum and teeth during pregnancy because periodontal disease can actually lead to preterm labor. And then the GI system, it just slows down. So some pyrosis, constipation. So what's some things that you would tell your client if she was having a lot of heartburn? What do you think would be some good things to tell her?
Stay away from spicy foods.
Okay, avoid a lot of spicy foods.
Stay upright about 30 to 45 minutes after eating.
Okay. Food tends to sit in the stomach a little bit longer. You know, it slows down the motility. Okay. What else would you tell her? What else could you tell her? Well, you could tell her to eat smaller meals, maybe more frequent, but smaller meals throughout the day is always a good thing to do. And then the ABO incompatibility that we will be talking about. I'll just say one thing. If your mother does not have an RH factor, in other words, if she is RH negative, she needs to be given Rogam. Okay. She'll be given it routinely, usually at 28 weeks. And then 72 hours after delivery. Okay. So if she's negative, that's when we're concerned. But if she's RH positive, we don't need to be concerned about it. And then you have pictures in your book also talking about Leopold maneuvers. This is just a way of, from the outside, externally, palpating to see what lie the baby is in, what part, where is the head, where is the spine and the butt. So we can get an idea. And it's usually done late in pregnancy towards delivery to verify what position and everything the baby is in. That's what Leopold maneuvers are. So probable signs of pregnancy are which of the following? Do you remember what we talked about? Remember, Abby came into the office, presumptive, probable, and positive. What are the probable signs? She's probably pregnant because, do you remember?
The diagnostic test.
Nope.
Is it
That
B?
would be it's B, the observation by you, the nurse, what you see. Yep, that's correct. That's correct. I know that this is a lot of information for you, but you'll have time to look over it again. Just go over it. Okay, let's see. Let's do a question from last week. I don't want you to forget what we talked about last week, because last week we started with some foundation information, and this week we added to it. Okay, we're building on a pregnant woman. What could affect her pregnancy from her medical history and her family history and her lifestyle. And then when she becomes pregnant, what testing do we need to do? And how do we follow up? What's going on with her body? what's going on with the baby. Okay, so this one is a cultural question. Okay, so 19-year-old woman who is pregnant for the very first time. She presents for care on the labor and delivery triage unit. So she's been pregnant a while. Okay, on initial assessment, the patient and fetus are in stable condition, and the provider admits the patient in early labor, and the patient is accompanied by her mother. They both speak very little English and have found it difficult to answer questions. The nurse is preparing to engage with the patient through an interpreter and is considering how best to prioritize care and utilize the interpreter service. So this is a kind of question that you're going to see on the next gen. They're going to give you a case, and what they want you to do is identify the essential information. In other words, what actions as a nurse should she take? What is indicated? In other words, do this, contraindicated, don't do this, or it's not important at the time. Okay, so let's talk about her. Remember, she's in labor and delivery in early labor, and she doesn't speak much English. Okay, and she's got the interpreter. So let's look at the first one. It says, ask the patient if she has any preferences or requests that are important for you to know about during her labor and birth. Is that indicated? Contraindicated? It really is, isn't it? You want to know culturally, what does she want? What does she expect? What is she used to? Or what is her family used to? Very much. Begin the conversation by discussing the latest news and political unrest taking place in the patient's country of origin.
Non-essential.
Non-essential. Unrest is everywhere in the world now. Engage in eye contact with the patient and her mother while speaking through the interpreter.
Indicated.
Be mindful that there are some cultures that they don't like eye contact. So just be a little sensitive to that. When you're talking to them and you're trying to contact, look them in the eye, if they turn away, then accept it. What about invite the patient and her mother to ask questions, explaining that the nurse and staff want to be responsive to their needs?
Indicated.
It's indicated. Yeah, you need to communicate that. And tell the interpreter to take the lead on asking questions because they know what to ask from working on the unit before.
Contraindicated.
Contraindicated, that, yeah. Okay. And lastly, ask the patient if she plans to have her newborn circumcised if she gives birth to a boy.
Indicated.
What does everybody think? You think that's indicated? During labor, I think it's kind of non-essential at this point. You can always discuss that after delivery. Yeah, I think it's non-essential. So that's a type of NGN, next generation nurse question. Okay. It takes a little bit of judgment.
I have a question.
Yes.
With that last one, ask the patient about what was that? About circumcision. Yes. So you said that was what, non-essential?
Yeah, she's in labor.
Is it because of is it because of that whole labor process? And
Yeah.
now if the question is asking with postpartum, that would be more indicated, right?
Yeah.
Okay.
Yeah. Yeah, it's more indicated in the postpartum period. That's a good question, though. Good question. So some more review for you. So I think I sent you these pictures too to describe prima gravida and nulliparous, a client with her very first pregnancy. So she's a prima gravida. Gravida, remember, means conception or pregnant. Okay, and it's her first one. So prima gravida. Nulliparous because she's never had a pregnancy delivered after 20 weeks. A client with 2 or more pregnancies, but only one with a 21 pregnancy with 20-week delivery is considered multigravida because she's been pregnant 2 or more times, but a prima para because she's only had one deliver after 20 weeks. Okay. And then a multigravida and multipara. She's had 2 or more children and 2 or more deliveries after 20 weeks. And then one more, multigravida, but nulliparous. So this would be someone who's had maybe 2 abortions or 2 miscarriages, and she's never carried a baby to the 20th week. So she's multigravida because she's conceived 2 or more times, but she's never had a baby past the 20th week. Okay. Yeah. Okay. Let's see, what else do I have? The GTPA. There is a video I put in this one. I sent to you at the bottom is a Quizlet about GTPAL. So if you feel uncomfortable, it wouldn't be a bad idea to jump on this and watch this video to practice. Okay, if you want to do that, it's Quizlet right here. If the link doesn't work, you just have to copy and paste it.
Can I ask you a question, Professor Zeller?
Yeah. Uh-huh.
So I was looking in the book and on like page 231, it's talking about the hydramnios.
Hydramnios.
Yeah, the O1 and the P1, but it doesn't say what causes either one of those. It just
Okay.
says like what it is. Can you tell
So
me where to find that?
what is it? What is polyhydramnios?
That is too much amniotic fluid, and the other one is not enough, like less than 300 mils.
Okay.
But
So
I don't know.
So polyhydramnios is having a lot of amniotic fluid. Oligohydramnios is not having enough, okay, a lower volume, okay? We're concerned about the low volume more than we are the high volume, okay? Polyhydramnios is going into high risk, okay? Diabetics, okay, diabetics. So, for example, when you are showing symptoms of diabetes, drinking a lot, wanting to eat a lot, want to urinate a lot, those kinds of things. If you have hyperglycemia during pregnancy, your fetus is doing the same thing, drinking a lot, peeing a lot, okay? They get big, they produce a lot of amniotic fluid because they're urinating a lot. Amniotic fluid comes from the fetal lungs and the urine, okay? The urine is sterile during pregnancy. So when we have a diabetic, we see polyhydramnios usually. Does that help?
Yeah. Do you know about the other one where it's not enough?
Oligohydramnios? We don't always know what causes that, but one thing that it could mean is that the fetus, the kidneys are not producing urine or not producing enough urine. So it's a sign of maybe some kidney malformation, kidney defect of some sort, renal defect.
Is that in the fetus or the mother?
The fetus. If there's low fluid around the baby, the fluid comes from the baby's lungs and the urine. And if the baby doesn't produce enough urine, that you're going to have a lower volume of fluid. That's one end. Other indications, we don't always know why. Oh, Crystal can't hear us. Uh-oh. Well, hopefully, Crystal, you'll be able to calculations sessions you'll be able to watch the recording. I hate that. I don't know why you can't hear. You probably should shut your computer off and turn it back on. That's what I have to do. Okay. Yeah, that's frustrating. Okay. Any other questions? So this week, you're in your assignments. You've got your unintended pregnancy discussion. Now remember, you need to put your initial posting Wednesday by midnight. Okay. I gave you the article I want you to read. It's about preconception care, and you have your resource. Okay, you have your resource. Read the article, and then you don't have to discuss the whole article. Just answer. The question is asking you about strategies, knowing that half of the pregnancies in the world are unplanned. What are some strategies as nurses that we can or should do that increase the outcomes of pregnancies? Because we have a high mortality rate for newborns. So what can we do? And look at the different areas they talk about. They talk about diabetes, they talk about chronic diseases and stuff like that. Look at one of those areas and just focus on that particular area to answer the questions. Okay. If you still need some help with that, I can help you. But I think once you look at that article, you'll have a better idea. So just pick one area that you think we could do to help clients. Okay. And that's a homework grade. It's 1% of your, all your discussion posts are 1%. Okay. I'm very lenient on them, but it's a great opportunity to learn something. So do the best you can. I did do the math video for you. So let me talk to you a little bit. So you have your ectopic case study to do this week as well. So those are your 2 assignments. So next week is week 3. Week 3 is what we call our exam preparation week. Okay, because you have your first exam in week 4. Okay, 2 weeks from today. So next week we're going to get ready. We'll talk about labor and delivery next week. And you'll have that information too. So the review sessions, we call them, or study sessions, will include next week's content. So what the instructors are doing for you to help you prepare for the exam is to hold a session, an extra Zoom session. Each of the 7 instructors are going to be holding a session, and I'll get that schedule out to you at the end of this week. Okay, and you can attend that session, and it's recommended that you go to at least 2 sessions, the optional times, and they're going to be different days on different times, okay, that you can choose from. And then you'll have the recording of those sessions. So if you're unable to make more than one, you can at least watch another recording. It really does help. We do that, plus we give you a PowerPoint as a guide for your study. It's really good. we also have some short videos pre-recorded for you talking about early pregnancy, talking about labor and delivery and stuff like that. So they're very short videos each of the instructors have done. So we'll give that to you. So you have a lot. So if today you feel overwhelmed, well, don't try not to feel overwhelmed right now. Okay. Look at the PowerPoints again. If you don't understand the PowerPoints, go to the book, look at the book and find the details. Ask me to meet with you to go over what you want to go over, and then attend and listen to videos. And this will help you. So next week, when we talk about labor and delivery, we're going to pull everything together again so that you're more prepared for the exam. Okay. And I'll be glad to meet with any of you one-on-one to help you prepare for the exam. It really does help, because I know it's a lot of information and there might be a lot of new terms for you. And I understand that. I understand that. Okay. Any questions about any of that? You have all been on ExamSoft before, right? Okay. Okay. So next week we'll talk more about the actual exam time. I want to show you another kind of next gen question that I worked on this morning. Okay. Says we have a few more minutes. This is similar. It's not exactly like, get rid of that thing behind me. It's not exactly like a bow tie, similar. So a bow tie question, it's a next gen style that you'll see on the next gen, takes one concept and puts it right in the middle. And then right before it and right after, there's information. So it's like a bow tie, okay? So what we do on the left side of the screen, we are the things that are occurring that either cause the central concept or are risk factors for it. And on the right side are follow-up or actions that we take. Okay, so this is similar. So what I've done here, my concept is a 40-year-old antepartum client at 12 weeks gestation. So what's one thing you know about a 40-year-old pregnant woman?
High risk.
Because of her age, right?
Mhm.
She's got old eggs.
Old
Truly.
eggs.
Yeah, old eggs. Because when she was a fetus is when she got her eggs. And even throughout her fetal life, she's losing eggs. And by the time she's born, she's lost a lot of eggs already. The same eggs are there until now she's 40. So they're 41 years old. Okay. So she's got old eggs. She's at risk for Down syndrome and other things. She's at risk because of chronic disease. By 40, you might have high blood pressure. Okay. So let's talk about what things would you expect. The way we're going to do this, in the first column here, what things, now that we know we have a 40-year-old, what are some things from the list below that we need to do for her?
Carrier screening.
Carrier screen. We do that routinely. So we'll do some carrier screening. Okay. And maybe I can. We'll put that up there. Okay. What else do we want to do for a 40-year-old at 20 weeks? I'm sorry, 12 weeks. Now, why would you do an amniocentesis? Why?
Can't you check for like Downs and genetic defects that way?
Not genetic defects, but we could check for Downs that way, but there's something we can do that's less invasive first. What would we do first?
Maternal markers serum?
Exactly. Yes, yes. So when we do check the mother's blood for AFP and HCG, remember those are the markers. If they're elevated, if the AFP or the HCG are abnormal, then we would do the amniocentesis, okay? Then we could do the amniocentesis, okay? All right, what else would we do for her?
Blood work. And the glucose
Okay.
tolerance.
We don't do glucose tolerance at 12 weeks.
Oh, sorry, too early.
I think it's the
Yeah.
fundal height. And
Fundal height at-
ultrasound. Yeah.
Okay, we could definitely do an ultrasound, but we don't do fundal height much before 20 weeks.
Okay, so not that.
Okay. So we are going to do some blood work. Of course, that's what maternal serum markers are, but we also need to look at her blood type and check her thyroid. What else? Anything else?
What about the non-stress test?
Not at 12 weeks. That's third trimester. Yep. The non-stress test and the contraction stress test are, that's in another PowerPoint, I think.
It's not a pap smear, is it?
If she hasn't had one in a while, we definitely need to do cultures. So we'll just put that up there and pretend like it's cultures. Okay. But the rest of this stuff we don't do on a 40-year-old. Now, if she had heart disease, yes, we would do an EKG. Okay. We could do a chest x-ray if she has some kind of lung disease. Glucose tolerance test is later. Contraction test and a non-stress test is late second and third trimester tests. Okay. So maternal serum markers. Let's go to the next one. So let's say they were abnormal. Okay, now we have maternal serum markers that are abnormal. Low AFP and a high HCG. What does that indicate?
NDT.
No, low
Inadequate
AFP.
folic acid.
I'm sorry?
Is it inadequate folic acid?
Downs.
Nope. Down syndrome.
Down.
Low down. Low down. Low down syndrome. So what would we do if we were suspecting Down syndrome with a low AFP and a high HCG? What's the next thing we would do? This is
Have
a
to
blood
ask the
test.
mom if they want the amnio, and
You'd-
I guess if they
ultrasound?
consent, then do it.
Wouldn't you do
We're
an
gonna do it-
ultrasound?
We're going to do an ultrasound first. Okay, and then an amniocentesis. Okay, that's the order we would do it in. So if her blood indicates there's a risk, the level of AFP is too low, we're going to first do an ultrasound, okay, to see anything obvious. If the baby had at 12 weeks, let's say she's later, she's 15 weeks, we can do the ultrasound and see anything obvious. So if a baby has Down syndrome, they're not going to have a nasal bone. Okay, they're going to have nuchal translucency is going to be thick. Okay, their arms and their legs are going to be shorter. So sometimes we can see some indication on an ultrasound, but that's not diagnostic. So then we can do the amniocentesis at week 15. Okay, all right. What else would we do for her? What if, let me put this back. Whoops. Put this down here. Put everything away. So what if she had a family history of spina bifida? What would we want to do?
Carrier screen.
Carrier screen is about genes. We're talking about defects.
An ultrasound.
An ultrasound. Yeah, we definitely would like to get an early ultrasound. And of course, we're gonna do our screening for the maternal serum. Oh, we got abnormal already. All right. So abnormal. What if her AFP is high?
NTD.
That would be neural tube defects, yes. And once again, we would do the ultrasound and then the amniocentesis. Okay, so we do the same things. We want to look at the ultrasound to see if there's any indications, and then it's followed with an amniocentesis. I know that there are questions on the exam about that, the order of how we do something, okay?
So
All right.
basically start with the least invasive and work your way up.
Exactly. We're going to start with the least invasive, the highest priority, and go from there. So I'm practicing doing these because this just helps you with follow through. Okay. What if you have a 38-year-old client? Are they at risk? Yeah. So what if you have a client? Let me do this. 30, let's see, let's do 34-week gestation. And I know we haven't talked about high risk or anything, but you still need to know about these tests. I don't know why, but that's just the way they have it set up. 34-week gestation. And she's telling you she hasn't felt the baby move much. She's 34 weeks. Do you know what we do for her?
Non-stress test.
Do you put her on the
Exactly.
monitor?
Yeah, and that's what the non-stress test is. So let me find non-stress test. Where did I put it?
It's up on the right-hand side.
I know, but I was looking for pictures of it. I can't remember what slides that I put it under, but anyway. So the non-stress test is the only thing you need to know about it is that it's just a way of looking at a fetal monitor. And I can't believe I don't have it here. Looking at the monitor and looking at the baby's heart rate. Okay, so we'll put a monitor on mom, look at the heart rate, and mother tells us when she feels the baby moving and she pushes a button. So when we see the button being marked, or it comes up on the screen and it marks the rhythm strip or the heart rate strip. If we notice a correlation between the movement of the baby and the heart rate of the baby going up, it's good. Okay, so a non-stress test, I need to look for that. Let's see, do I put it in here? Yes, here we go. Let me show you the difference, then we'll be finished. Okay, so the non-stress test, what we want to see here, this is in the other slice that I didn't do today. So we want to see the heart rate of the baby go up when the baby moves. And that means it's reactive, it's positive, it's good, it's reassuring. So if you look here, we see down at the bottom, those straight up and down is when the baby's moving, because that's when mom pushes the button down here. Okay, up at the top is the rate of the baby. And you can see when the mother pushes the button, you can see how that heart rate goes up. Okay, right here. Ooh. And then it goes back to baseline in this long section here when baby's not moving. So we do that. And this is in this PowerPoint. Okay, which is from week 10. I'm sorry, chapter 10. Okay, so we do that when we have a client in that third trimester that says she's not feeling the baby move, or if it's an adolescent like Abby, and she's late in her pregnancy and she's not feeling much movement, or the baby is not growing well, we'll do a non-stress test. Okay. Contraction stress test is she's in labor, or not she's in labor, she's close to labor, and we're concerned because the baby's having a lot of decelerations. So we're going to do a contraction stress test. Okay. So I'm practicing on bow tie. This is all new to all of us teachers too. Okay, lots of information today, but everything I talked about today is in something I gave you. Okay. So all the documents and stuff that I try to give to you so you can begin to chew on it, study it. Okay. Yeah.
You're still going to
Right.
send that first paragraph, though, right?
Which one was that? Oh, yeah, the pregnancy case, Abby's case. Yes.
Yes.
Yeah, I will do that. Yes. Thank you, Crystal.
All right,
I say
thank
you got your computer fixed. You got your computer
I had to
fixed.
go. I had to swap to a different computer.
Oh, yeah. Yeah. Sometimes I Zoom my computer. I have this is a fairly new computer. Sometimes I Zoom, my speakers don't work right. I have to shut my computer down and restart it, and then it's fine. Who knows? We can't always figure all that stuff out. Thank you.
I got a
It's
question.
5. Yes.
Sorry.
No apologies needed.
But next week it says there's quiz number 2.
Yes.
What
I forgot about quiz number 2 next week. Yes.
is that gonna be under? Like what chapters?
So it'll be from a lot of today's content. Okay. And then 2 questions from labor and delivery that we're talking about next week. Okay. 2
Okay.
questions. So 7 questions from today, 2 questions for labor and delivery, and then 1 math. Did you feel the math was difficult on today's quiz? No? Okay.
I got one more question. I'm sorry.
Please.
So with Saunders, the 50 review questions, can we specialize into one category, like per se, like OB for all those 50 questions? Is that okay?
You have to.
Okay.
You have to. You have to choose OB, and I'll show you how to do that next week. You have to choose Monday. During class, I can show you that, or before, after the quiz, I'll show you. You have to choose maternity, and what you're choosing is the subcategory. You're going to choose antepartum and intrapartum. Okay. I tell you what, I'll open those up for you later this week so you can see and begin to work on it. You have to do 50 questions at one sitting. Okay, so at least look at them and maybe do 10 just to see what I mean by subcategory. But I'll show you next week how to do that. Okay. Anything else?
Yes. With those slides that we went through, will you be able to post that on our weekly modules?
No, not on the modules. They're in the announcements.
Okay, like the PowerPoint slides that we went through today.
They're in the announcement, except for the adolescent case study, but that Crystal asked about. Yeah, there. If you should be looking at the announcements, every day to make sure I don't add. Do you know what I mean by the announcements in Canvas?
Yes, I've seen it, but there's just a lot of announcements. I had to scroll all the way down.
Yeah. Yeah. So week 1 is at the bottom, and then you'll see week 2, week 3, week 4, and that's why I put all of the documents and stuff. Yeah. Yeah. I'm sorry. I know there's a lot of announcements. Yeah. All right. Anything else? Thomas is relaxed and kicked back. You can sign off. You don't have to hang on. I appreciate all of you being so kind.
I appreciate it.
Yeah.
And then also you